So Brad, there's a couple data sets that are going to read out soon. The one we just talked about in the study with comparing it to chemotherapy. So let's say acalabrutinib gets approved for CLL. What's your thoughts? How are you going to use it? Are you going to switch everyone over to acalabrutinib? Is it going to be your drug of choice? Or are you going to stick with ibrutinib? What do you think?
My experience with acalabrutinib has been similar to the other panelists. I often find it to be a little better tolerated than ibrutinib for some of these nagging chronic toxicities, the hypertension with ibrutinib, that can be a problem, the bleeding, the myalgias, the arthralgias. So assuming acalabrutinib does get an indication in CLL, I could easily see it being my preferred BTK inhibitor when I'm opting for a BTK inhibitor.
We're going to move to yet another BTK inhibitor, John. So there's zanubrutinib, used to be BGB 3111. There's a variety of data sets that have been presented. What is the advantage of this? Is it just another BTK inhibitor?
Well, time will tell, and I think it's another a valuable drug. It's important to have another tool that we can use. It just makes things a little bit more confusing perhaps because it's not clear where it differentiates itself at this point. Part of the problem that we have with zanubrutinib to this point is that we don't have a lot of experience with it in the United States. It was almost all tested outside the United States, so we need to gain a lot more experience with it. The good thing is that there is a randomized trial, direct head-to-head versus ibrutinib in CLL patients, and that will be very helpful for understanding the differences there. It won't tell us about the difference compared to acalabrutinib. They do look to be relatively similar drugs, and I think at the end of the day, what we've been talking about, which will perhaps win in the clinic, is what's the most tolerable here. Again, we're not curing these patients probably, certainly not with single agents. We're palliating them, and we want to keep them away from the community oncologist's office as long as we possibly can. They want to be taking their pill and doing their normal day-to-day things.
Matt, you've treated some patients with it. Anything that comes to mind in terms of differentiates it from other BTK inhibitors?
I mean, I think based on my experience and my interpretation of the data that it seems most similar to acalabrutinib. So, it's more selective for BTK, zanubrutinib, and compared to ibrutinib, and in my experience, does seem to be a bit better tolerated. So, I think of it in that way. I think one of the issues with all three of these BTK inhibitors that we've talked about is that for some of these high-risk patients who become resistant, they can develop this BTK C481S mutation, and that actually would make them resistant to any of these three BTK inhibitors. So another topic for another day, perhaps, but there's a whole new generation of drugs that can potentially target that mutation.
Right. Yeah. You're alluding to the non-covalently bound drugs that are in development that hopefully will overcome some of these mutations. Right. So before we move on to mantle cell lymphoma, any sort of final thoughts on the community oncologists as they make their way through all these different treatment options? And it's hard to summarize in one sentence, but John?
Well, I think the important thing is to know who you're treating. What are the comorbidities or the issues around that specific individual patient? And that helps a community oncologist figure out what the right therapy is. It's important to remember that venetoclax can cause tumor lysis that can be very significant. So you have to know how to use that, especially in the community. You have to be well familiar with that. And I would encourage any community oncologist to really have a direct line of communication with a CLL expert at any point, and especially in trying to figure out which of these drugs to use. A little conversation there certainly would go a long way in many cases.